Great. Thank you to the Society, and I welcome the opportunity to give a short talk this morning about the optimal timing of primary repair. So the first thing that I'll have to say is that I presume that we are talking about the cyanotic neonate, because clearly for the pink tet or the acyanotic neonate, I think the data is pretty clear. And I think all the surgeons and interventionalists would agree that somewhere in the 4 to 6 month time point is the optimal time for a repair. So the question becomes, what do you do with the cyanotic patient with tetralogy of Fallot who is either a newborn, has atresia, or becomes cyanotic shortly after birth? And I respond with this because at our institution, there's potentially no greater question that leads to more gentle discussion in our conferences than this particular question. And you could see, one of these superheroes is Dr. Ng, and the other one is Dr. Starnes, and they each have their own opinion upon the matter. And I think the primary problem is we have so many excellent interventions these days. And let me first make the point that all of them can offer an excellent repair or an excellent outcome for your children. There's obviously a palliative surgery, and I'll go through some of these afterwards. The classic modified BT shunt, the right ventricular outflow tract patch, obviously new palliative interventions like ductal stenting and stenting of the right ventricular outflow tract, and of course early primary complete repair. And the question is twofold. One is early primary complete repair ideal, or do the potential risks and complications of this early repair outweigh what are really excellent potential options, both surgery and interventional approaches that offer both low morbidity and excellent long-term outcomes? I think it's very important to recognize and respect your institutional capabilities. For instance, it does no good to anybody is if you try and follow the advice at one particular institution, if your institution does not have the ability to do those same things. For instance, there are many outstanding reports of early tetralogy repair from outstanding institutions, but if you don't have experienced neonatal surgeons and a well-practiced and experienced ICU, then that's not the approach for you, right? It may be the ideal approach for some people, but it is not the ideal approach for you and your patients. So if you don't have the full spectrum of interventional techniques, then stenting the RV outflow tract, no matter what anybody says, is not for you. You must recognize what your own institution has and move forward from there. So with that in mind, let's go through some of these things. The BT shunt, it's very tried and true. It's got a long history and it's very durable. And I think that from a surgical point of view, the most important thing is it has a known delivery of blood flow, right? If you are a 3.5 kilo baby, you're gonna get a 3.5 millimeter shunt. It's very well recognized, it's very defined. You know how much blood flow they're going to have, and you know that that's going to be sufficient. That's not necessarily the case, as we'll see with a right ventricular outflow tract patch. But there are also many problems. The most important problem to me is that you have a period of high susceptibility to acute thrombosis. The baby gets dehydrated at home, gets sick, has a viral infection, and next thing you know that you'll have a problem. The other thing is that if the child is less than 2 kilograms, the use of a BT shunt, I think, in my opinion, is not indicated. I think that 3 millimeter conduits have an unacceptably high risk of stenosis or acute thrombosis, and they also have a tendency to kink a very small pulmonary artery. And so for children less than 2 kilograms, I think there are better options. That being said, it's the right ventricular outflow tract patch. Many institutions, including our own, use this. I think it reestablishes antegrade blood flow, and especially in the setting of atresia, I think that reestablishment of continuity between the heart and the pulmonary tree is very important, and I think it's very durable and it's less susceptible to thrombosis. I put that it allows for operative visualization of the VSD. This has both pluses and minuses. Sometimes when you see the VSD there, you are tempted to close it because it's staring at you, and you must fight with yourself sometimes not to close it. But we'll go over that later on. As I said before, there is a tendency to oversize your blood flow, in other words, make the patch too big, but I usually size it over a sizer, so I put it somewhere in a 5 or 6 millimeter, make it the equivalent of a 5 or 6 millimeter sano. And then there's ductal stenting, and I'll show you some data later on about ductal stenting, but the potential advantages are, of course, avoiding surgery. You avoid mediastinal adhesions. You avoid pulmonary artery distortion, and you have even distribution of pulmonary blood flow. I do think, though, that there is mixed data on morbidity and mortality. I think it's not applicable to all patients, and obviously there are some important considerations such as LPA stenosis. If you do not have hybrid facilities that you're doing and you happen to get into a problem, although it is rare with acute deep cyanosis, transition to ECMO or to cardiopulmonary bypass can be time-consuming and a little problematic. And in some circumstances, you may need alternative access, such as carotid artery cut-downs, which of course adds yet another incision to your operative plan. And then there's the right ventricular outflow tract stent. Obviously, it's recently gotten some good press from Toronto, but I believe the advantages are also that it relieves RV pressure, which a ductal stent does not, and certainly it has the potential to remove the stimulus for further hypertrophy and fibrosis. You have the advantage of antegrade blood flow, but as you can read, there's also problems, including potentially a more difficult and challenging operation in removing it at time of complete repair. So, all of those need to be weighed against early complete repair. We can read the advantages. We restore a biventricular circulation. We remove this hypertrophic stimulus. We avoid risks of a palliative procedure, and there are a number of significant psychologic, social, and economic benefits. But early complete repair, and what I'm talking about here is repair in the 1 to 2 month range, has increased intubation times, ICU stay, hospital length of stay. There's increased technical complexity, there's no question about it. You'll often speak with some surgeons and they say, oh, it's an easy and straightforward case. I don't believe so. Having had a significant neonatal experience, I do not believe that to be an accurate statement. You will have increased clamp times. Your ventricular incision, if you choose to do that, will be potentially longer. You are at increased risk of tearing the myocardium or tricuspid valve. If you go through the atrium, you may have to take down the tricuspid valve in order to close the VSD, particularly if there's a lot of malalignment. And you may have to use deep hypothermic arrest. And if you look at the available data on early complete repair, it is either often a anecdotal single surgeon or institutional experience, or they describe not neonatal operations, but earlier operations. For instance, there's a well-regarded series, but if you look at the mean age of the patient, it's well over 2 months, and the weight is at 5 kilograms. So that's the mean. So that means that actually half of the patients they report on weigh more than 5 kilograms and are in fact older than 2 months, which I wouldn't consider early repair, but more a standard repair. But nonetheless, there are some excellent institutions with excellent results. So the question is what do I do? And what would I advocate for in my patients? I believe that neonatal or early primary repair increases the risk of morbidity and mortality within this critical neonatal period. Again, that's not to say that outstanding results can't be had at other institutions, but I believe that even in outstanding excellence institutions such as our own, I believe that the repair can be achieved with greater success and better outcomes at a later time period. And so I definitely do not advocate for early complete repair. As far as what kind of palliative strategy to take, I think that interventional approaches have great potential to reduce the morbidity of carefully selected patients. But I also would say that the clear indications for these procedures, such as ductal stenting and RV outflow tract stenting, have not been delineated. The literature doesn't support the necessarily reduced morbidity and mortality. And there are real risks of acute hypoxia and hemodynamic instability that do not occur in the operating room. And in fact, if you look at all the reports in the modern era of ductal stenting, the unplanned reintervention rate and mortality are consistently significantly higher for ductal arterial stenting than they are for classic BT shunts. Now, of course, these are selected patients, right? Generally speaking, the ductal stent literature, the reason why they underwent ductal stenting was because they were sicker, or perhaps they weren't ideal candidates for surgery. But nonetheless, the current available literature suggests that the morbidity and mortality for ductal stenting is higher than that for BT shunts. I think the literature for right ventricular outflow tract stenting is even is much fewer and has less data available. But I think that the approach of the antegrade RV outflow tract patch is inherently better. And I think it's more stable and more physiologic and more versatile than a BT shunt. I think it allows for simultaneous LPA patching. You can visualize the VSD. And, you know, cardiopulmonary bypass, which is often cited as a problem or one reason why you need to or you should potentially take a interventional approach, and why, for instance, ductal or BT shunt would be better than an RV outflow tract patch. Well, if you are going to the operating room for cyanosis, you're going to be on bypass. You're not going to take a acutely cyanotic child who needs to have some intervention, and it would be unlikely, especially if the duct is closed, that you'll be able to complete a BT shunt without the use of cardiopulmonary bypass. So, in any event, short introduction to our day. I believe that excellent results can be obtained for all management strategies, and all the data must be reinterpreted by what your institutional capabilities and expertise is. As a as an outline, my personal strategy is that I believe that for the cyanotic tetralogy of Fallot, they should undergo initial palliation. My own preference is for primary RV outflow tract patching. I do believe that interventional procedures can be safe and effective in selective cases, and I think that the ideal time for primary repair is greater than 3 months of age. Thanks.